Dr. Whiteley, welcome. Thank you so much for being here today.
Hi, Lindsay. Lovely to see you again. Hi.
Yeah, lovely to see you too. It's time for me to do another post about pelvic congestion syndrome for the blog. And I reached out to you because I've seen a lot of dialogue on the internet, especially among patients on the internet who go back and forth about the diagnostic techniques for pelvic congestion syndrome. And since I've come to the Whiteley Clinic and I've actually had your diagnostic procedure done and have had a successful treatment, I wanted to bring you on and talk about the way that you guys have developed how to best diagnose pelvic congestion syndrome. And so can you tell us about the protocol and why it's the best diagnostic tool over venograms or other types of sonograms or CT scans or MRIs? Can you talk about that?
Certainly, yes. I mean, the first thing is why doctors promote certain things tends to be that they do whatever they're comfortable with and what they've got. So if they've got a CT scanner or they've got a venogram suite, they'll use that. And what the trouble with doctors is what we don't do on the whole, and that's what makes us researchers, those people who don't act like this, is what researchers tend to do is say, right, let's think about the disease we're looking at and what is the optimal way to look at it, whether we've got it or not. You know, let's think about the logic and start from there. So this is why we've gone with venous duplex, because we know from all the research we did back in the 1980s and 1990s for leg varicose veins, we know that most of the problem in vein disease, whether it's pelvic veins or leg veins, is the valves don't work and the blood falls the wrong way against gravity. And we found out in the 80s and 90s that if you want to look at blood falling down the varicose veins in the legs, there's no point in doing an MRI or a CT or a venogram because you don't see the flow very well. You just see the veins and whether they're blocked or not. And venogram, although some people say you see flow in venograms, you don't really, because the contrast is heavy and cold. It doesn't flow like blood. Whereas with duplex ultrasound, we now know that that's the gold standard for leg varicose veins, because you stand the patient up, you squeeze the leg, you see the blood shoot up, and you can see that with the duplex ultrasound because the ultrasound bounces off the blood cells, so you can see the flow. And then when you let go, all the valves close and there's no flow back, normal, or the valves have given way and you see the flow back, abnormal. So nobody would argue at all since the mid-90s, nobody would argue that if you want to look at venous disease in the legs, you have to use duplex ultrasound and you have to use the patient either lying at an angle or standing up. So then we suddenly go into the pelvis and suddenly doctors get really twitchy and they get really worried because it's deep inside. And as soon as you think deep inside, they think, oh, we must use a CT or an MRI. But the trouble with those is you're lying flat. And if you're lying flat, there's no backward flow with gravity. So they're useless to begin with. There are people now trying to invent ways of holding your breath and squeezing, a thing called Valsalva, to try and make blood flow backwards to see it. But those two modalities, CT and MRI, they're not very good for flow in any case, especially not specific flow. Venography, you can sometimes see backward flow, but again, it's non-physiological. With duplex ultrasound, just the same argument as 20 years ago in the legs, we can actually see the retrograde flow. We can see the reflux. If we can use the duplex ultrasound, the Doppler on it, to see the blood going upwards and downwards. So when you squeeze your buttocks or when you give a big Valsalva, you can make the blood flow up or down. So what Judy Holdstock invented with a lady called Charmaine Harrison, and now Angie White has joined us as well. And what my sonographers, what they've all shown is if you lie the patient at 45 degrees, then you've got gravity. If you use a transvaginal duplex ultrasound, you can see all the veins in the pelvis that cause the pelvic congestion, so the internal iliacs and the ovarian veins. And it's important to remember it's not just ovarian veins, it's all four veins, 2 internal iliac, 2 ovarians. And the patient gives either a squeeze of their buttocks and lets go, that squishes the blood up. And then if the valves are working, it stays up. If the valves aren't working, it falls down. Or you can get the patient to do what's called a Valsalva, where they squash they like breathe out really quickly, but against a closed mouth. And that forces blood down. And again, you can see if the valves are working or not. And what we've shown is when you compare that test with what we find success or failure at venography. So in other words, not just what the venogram says, because that's not a good gold standard, but what we find when we treat the patient, whether you get a good result or not. It is currently the gold standard test. Now, there are people who do venous ultrasound from the outside, so in other words, transabdominally, but the trouble with doing that is you can't see the veins at the bottom of the pelvis that cause the problem. And unless you're very, very slim, it's very hard to see those veins because they're right at the back as well. So the gold standard test now is the pelvic ultrasound transvaginally at 45 degrees using what's called the Holdstock-Harrison protocol. And then using preparation to empty the bowel, looking at the veins upper in the abdomen to check there isn't a Nutcracker syndrome or a May-Thurner. So we do and that's the Holdstock-White protocol. That's what Angie brought with Judy Holdstock. And so by looking at both of those, we can look for the reflux, which is the main problem, and also check there isn't an obstruction, which is sometimes a problem, but not as commonly as the reflux. There is no other test really that shows reflux anywhere near as accurately as duplex ultrasound. That's why we use it. The trouble is it's a very skilled test that takes a long time to perfect, and that's why people are always looking for a quick second best, hence they still use MRI, CT, venography. But we often see people who come to us who have had treatment elsewhere based on those who still have reflux in veins that weren't treated.
No, that was my story.
Yeah, absolutely.
Yeah, I was diagnosed with a CT scan and only told that it was the ovarian vein, the left ovarian vein. And then sure enough, I get over there and Angie White does her magic on me, and I needed all 4 or 3 of my 4 pelvic veins embolized, which the CT scan only showed the 1. So,
and can I just say there's 2 reasons for that. Firstly, every doctor wants to find it's your left ovarian vein, because that's a nice long one, it's the easiest to treat, and it's the safest to treat. And they don't want to find the others because they can earn some money out of treating that, say they've done the job, and if you don't get better, well, it's your fault, not theirs, because they've done the job. So everyone wants to find this left ovarian, when in fact that actually isn't the commonest. It's the commonest is left ovarian of both internal iliacs. And the other thing about it is when you use CT, they look for big veins. And the idea being, if it's a big vein, it's abnormal. If it's a small vein, it's not. And we published in about 2014, we published a research study where we looked at reflux and versus diameter. And in fact, the correlation between reflux and diameter is very poor. Lots and lots of people have small veins that CT would say normal, but have massive reflux. And also lots of people have big veins that actually still work. So you should never use size of vein as the diagnostic criteria, and that's why CT and MRI are often inaccurate.
Okay, so I want to make sure I get the names of these diagnostic protocols correct. So the Holdstock-Harrison protocol is checking for the reflux in the veins using various positioning of the body, upright, lying flat, breathing, squeezing the buttocks. That's to diagnose pelvic congestion, correct?
Not quite. So Holdstock-Harrison was the first one, and that's transvaginal, always at 45 degrees.
Okay.
So 45 degrees, so using gravity. Transvaginal, so you can see the veins right in the pelvis, okay? But yes, then apart from that, you're right, you do the buttock squeezing, you do all the other bits and pieces, and that one's just to look for the reflux of the blood in the pelvis.
Okay, and then the Holdstock-White protocol is the lying backwards and checking for Nutcracker and the May-Thurner syndromes.
Absolutely, and what you'll find is a lot of people, and in the States it's very popular as well, a lot of people have been told they need stents, and they'll need it because they've got blocked or narrowed veins. And what Judy Holdstock and Angie White showed is that you can see, if you do a bowel prep first, so that you've got no gas in your bowel, and you lie the patient down, or you put them in 45 degrees, you can often see what looks like a narrowing of the vein. So a May-Thurner, if it's in the iliac vein, or a Nutcracker, if it's a left ovarian vein, you can see that narrowing. But we also know that when those patients have their coils, quite often the narrowing's not actually there. So what those 2 girls did, which was very, very clever, is they just started tipping people the other way up. So in other words, they said that perhaps it's the fact that blood is preferentially falling down veins without valves, and so the veins look narrowed because they're just empty because blood isn't going that way. And when you tip patients like flat and then the other way up, if the veins are really narrowed, then they stay narrowed, but almost all of them actually dilate up. And so it's an excellent test, non-invasively, to see who really needs a stent. And that's why in our series, we find that only about 2% of people need a stent. Whereas if you look at other patients, other series where they just look at the narrowness, when the patients are lying down, either with IVUS, the intravascular ultrasound, or using CT without any stress on the system, just flat, you'll find that sometimes up to 30 to 40% of people get a stent.
Yeah, so I was, before I found you, I was in a few Facebook support groups of patients with pelvic congestion syndrome. And by being in those groups, you would think that May-Thurner syndrome, Nutcracker syndrome, and pelvic congestion have to exist together, because all of these women were talking about how if you've been diagnosed with PCS, you need to get checked for Nutcracker. You probably have Nutcracker. I have May-Thurner. You probably have it too. And it just seemed like all of these three venous issues went together. And so I was, I mean, rightfully so, having a lot of anxiety about all of this, because all I had was a CT scan from an emergency room visit. And so I taught myself how to read CT scans, and I went through and I found my left renal vein. And sure enough, on my CT scan, it appeared to be squished. And so when I showed up to my American interventional radiologist appointment, he didn't even bring up Nutcracker syndrome first. I'm the one who brought it up. And then whenever I did bring it up, he scrolled through the images on the CT and he was like, oh yeah, sure enough, it looks like you probably have a Nutcracker, about a 50% compression here. And so I walked out just like, oh my gosh, I'm going to have this major surgery. I'm only 35 years old. I'm going to have a stent. Like it's going to be so expensive. Like just having all of this anxiety. And then I found your research and the article, the study that you published about Nutcracker and how rare it actually is, and the way that you test for it, and why a CT scan isn't the best way to diagnose a Nutcracker syndrome. I just felt so much relief. And then sure enough, I come over to the Whiteley clinic. Angie's doing her magic on me. When I'm sitting up, she's like, yeah, you've got some compression in your left renal vein. She lays me back and she goes, and it opened right up.
Yeah. And it's very interesting, because if you've got the the valves have gone in your left renal vein, blood coming out of your left kidney is going to fall preferentially down that vein, and so the next bit wants to collapse unless you tip the patient upside down and stop that reflux. So we've done so many cases since 2000 where people have thought they've had Nutcracker. We've put coils and blocked off the left renal vein, the left ovarian vein, and Nutcracker just disappears. I mean, we would be making all these women worse if we weren't right, but we're really cautious. There is another thing that's very, very important at this point, I think, that you need to know, and that is when you coil a vein, what you're doing is you're destroying it forever. You're stopping it fall back, just the same way that in the legs we use laser now to destroy veins, or radio frequency, or glue, all these other things. So we're very comfortable with destroying a vein, because when we destroy a vein, we only do it if you get the right tests. You only do it when you really have to stop that flow from falling backwards. The trouble with the stent is you're putting a foreign material in there to hold a vein open. Now the trouble is, when you destroy a vein, the healing process it stays blocked. So that's easy. You only get into trouble if it reopens again, which is very uncommon if you do it properly. But to hold a vein open is much more worrying, is much more difficult. So if you have a stent, especially as a young woman, you're going to really need to be checked for the rest of your life to make sure that stent stays open. And that's the problem. So my view is, as when I would lecture on this a lot, I say you have to really earn a stent. You have to know a stent has to be put in. If you blocked off a vein and on a CT or an MRI and it wasn't quite right to block that one off, your body will probably compensate. It's not going to cause much problem. But putting a stent in someone is a lifelong change. That vein has to stay open. And if you didn't need that stent, that's a big thing to have put in someone who doesn't need it.
Yeah, for sure. I'm so glad that I didn't need that, especially whenever I learned that stents maybe only have a 10-year shelf life, and that they can collapse, and that it seems like such a complicated, dangerous thing to not be certain about it. you know?
I think, yeah, there's the stents themselves are very good, and the companies that make them, they're really high quality things. It's the trouble is, it's the body's interaction with the stent. So when you put a coil in, you rely on the body interacting with it to block the vein off, and that's actually, we trick the body into blocking the vein off for us. The trouble with the stent is the body is is irritated, and it starts reacting by this thing called intimal hyperplasia or pseudo intimal hyperplasia, and so it's trying to actually or cause a scar tissue around that stent. Now that's fine if it scars into an open position, but with time it can hypertrophy, you can get more and more tissue, and you can actually cause a block off. Now it might be, say you've got a really severe nutcracker or a really severe May Thurner, you want 10 years of good life and then sort it out afterwards, fair enough. But if you didn't actually have that, it was a misdiagnosis. That's where the problem is. And the other thing is, if you've got a nutcracker, it shouldn't really be just diagnosed on CT or MRI. I mean, you should have a lot of kidney pain, you should have loin pain. It should be, you've got a lot of other things rather than just pelvic congestion, which is, much more common. And with May Thurner, you really should be looking at, if you're blocking off a vein in the leg, narrowing it, you should be getting some symptoms in your left leg as well. And so to have pelvic congestion without these other two things does make you think, if any narrowing I'm seeing, is it real? And I think, as I say, you really have to earn your stent.
Yeah, good advice. Okay, so the next question is if you and your team have developed this amazing diagnostic protocols and you've shown with research, you've published studies, you've done all of these things, why does it seem like y'all are the only ones who are doing this?
Well, we've run courses, and we have taught, and before COVID we did have more people starting to come and do it, and it's slowly taking off. The big problem is the commercial, and unfortunately it's a commercial problem. And what happens is a company or a hospital or a doctor will earn a lot more if they can just say to a patient, get in a CT scanner, it goes through, somebody reads it, and it's a nice easy thing to do, and everybody earns some money, and it's not a lot of effort. Whereas to do a Holdstock Harrison and then a Holdstock White protocol scan takes an experienced sonographer an hour, and that it's a big thing to do. And you're not going to be a doctor doing your own quick scan, like we know a lot of vein clinics, doctors like to do their own scans, again, for commercial reasons often. You need to have people who do these all day. And, in a whole day, you're only going to do 6 or 7 of them. And that's a whole day's work for a vascular technologist who's highly qualified. So commercially, it's not a great thing to do. And that's why clinics like ours that, basically are there for the quality rather than the commercial aspect. Even in England, there's a lot of clinics now springing up who are just, let's do the simplest veins and leave the difficult ones for other people, or let them go. And so I think one of the reasons the Whiteley Clinic is set up is we're set up because we want to be the best at what we do, and we don't look at the commercial side of it, which is my accountant is really upset about, as you can imagine. But we're trying to get the best figures with the view that then that will filter down to being, hopefully everyone will start doing the best. And that's really the issue. It's just people saying, well, we can get reasonable results if we just use what we've got already, and it's much easier, it's much quicker, and we don't have to go and train, and that's the problem, really.
Yeah, that's really sad. So is your clinic the only place in the world using these protocols, or do you know of other clinics that are regularly using these protocols?
At the moment we've trained a couple of people who we trained actually one lovely group from the States, and I can't remember offhand where they're working. But as I say, I'm not sure if they're using them at the moment. But we'll try and get hold of them. What we'll do is we'll start trying to put up things on our website as to people who have come and trained and who are using our protocols.
Okay. Well, if you think of the clinic, do you mind maybe sending me an email after the video and letting me know?
I will do. I will do that. Take a day. Yes.
Because that's I get probably 2 emails a week at least from people who have found what I've published on the blog about pelvic congestion syndrome. I have 5 posts currently. This will be the 6th. And I get these emails, and it's these women who have very, very sad stories. They're just desperate. They're anxious. They're depressed. They're tired. They haven't been able to live their lives to the fullest capacity in months, maybe years, and they're just at the end of their rope. And all I have known to do is to say, read everything I've put on my blog about pelvic congestion syndrome, and here's Dr. Whiteley's email. Like,
yes.
that's literally the only thing that I know to do. And then they always come back. Do you know of a clinic in the United States or in North America? Or do you know of a clinic? And I have to, like, very sadly say I don't. And periodically I'll email you, hey, do you know of a clinic? Is there anybody new? And it's just really sad. The state of healthcare in America is really sad, no matter what. But it's really sad hearing all of these different stories from women all over North America, and how it seems like their doctors are either just completely ignorant about pelvic congestion syndrome, or they have the typical, like, I'm in a white coat, I know what I'm talking about and you don't, and we're going to use an MRI, or we're going to use, I'm going to treat you with a hysterectomy or whatever. And it's like, they're not really giving women a lot of choice, I guess, or a lot of education about it. And it's just really, really sad.
I think that it's not just a problem in America, it's a problem actually worldwide, because the difficulty is the gynecologists who really should be interested in this just aren't interested, because they just want to find endometriosis, they want to do hysterectomies, they want to do laparoscopies, they want to do things that they're comfortable with. And if you look at all of the research that's been done in pelvic congestion syndrome, almost all of it has been done by venous surgeons like myself, or phlebologists. In fact, the guidelines were actually written from the UIP, which is the Union International Phlebology. No gynecologists involved at all. It's well known now, like in my book, I've written about it, because it's really upsetting that a third, when you look at all the papers, between 13% and 43%, so on average, about a third of women with pelvic pain who go to gynecologists have got pelvic congestion syndrome, and almost none of them even get told it's a possibility. Now, then that's because the gynecologists run these clinics. Now, if a whole group of doctors who see these women don't even know about it or don't want to talk about it, then of course that doesn't filter down to the family doctors and everyone, because they don't do the lectures, they don't do the talking about it. And we're right at the beginning stages of this, really. Sort of, as I said, we put the book out to try and get some interest. We've put lots of information out. You've been fantastic with your blogs, and it really is the beginning of a movement. But there is a lot of misinformation out there as well, and so some very scary stuff, which is just totally ludicrous. And I don't know why people do that. It's almost, we always know that there's sort of scare stories when anything's new, but there's some very, very good science. I mean, all our papers, we've just taken it very, very gently over 20 years and worked our way through, published our disasters, published our successes, been absolutely upfront about it. And then you suddenly see someone who's jumped on a bandwagon to say, oh my God, this is terrible. And some of the things they're saying are just patently wrong. But we do have to train doctors in not only pelvic congestion, but also leg veins, because the whole of venous surgery really needs an overhaul all around the world.
Yeah. So I just want to put this in as a plug, because I don't know if this is normal or not, but when I came over and had my scans afterwards, I was getting dressed, and I asked Angie, hey, while you're in here, could you just look at the back of my legs and tell me, do I have any beginning varicose veins? And she did, and she said, yeah, on the left side, it looks like you've got one. She pointed it out. It's right above my kneecap, or right above the back of my knee. And I was like, okay, So then I got the treatment, and about, I want to say 6 months later, I was getting dressed one morning, and I had a full-length mirror in my bathroom, and I turned around and I thought, I wonder if that vein's still there. And I felt it, and it was smaller, and you couldn't even see it under my skin anymore. It was, and so am I crazy to think that having my pelvic veins treated actually helped a potential varicose vein in my leg? Is that crazy?
No, it's not crazy at all. I mean, one of the things I wrote in my book, which is I've lectured all the time, is quite interesting. So if you talk to patients or doctors who are trained traditionally, and you talk about varicose veins, they think about from the toes to the groin. If you think about blood going back to your heart, it's from toes to heart.
Mm.
So for some reason, as soon as you talk about venous disease and varicose veins, people forget the pelvis and abdominal veins. It's all part of one system. And just because doctors like operating on veins in the leg because they feel safe and want to ignore the pelvis doesn't mean to say they don't exist. And the whole thing that when you have leg varicose veins,
Oh, hang on, Dr. Whiteley. Hang on, Dr. Whiteley.
down. And we know that if you look at women who have got leg varicose veins, so this is our research started. If you look at women who come with leg varicose veins, 1 in 6 have got them coming from the pelvis. And we've already shown and published the results that if you look at people who have come to have their legs redone because the first operation didn't work, the third most common cause is that the original surgeon didn't do the pelvic varicose veins. Now, what we don't know is the other way around. We don't know how many people with pelvic congestion get leg varicose veins because, of course, we haven't got the gynecologists involved. But it's all one system. It's all linked, and you need to really have phlebologists or venous surgeons dealing with this because they need to understand the leg varicose veins as well as the pelvic. Now, in the past, people have thought that leg varicose veins are only cosmetic, but we've already had the first patient who has had a leg ulcer because of pelvic vein reflux. And the varicose veins came all the way from the pelvis, all the way down the legs, and caused a leg ulcer. We fixed the pelvic veins and the ulcer started to heal. We then sclerotherapy the veins in the legs and the ulcers disappeared. So what was traditionally thought to be pelvic congestion over there, leg varicose veins over there, ulcers over there, it's all one condition. It's venous disease.
Yeah. Wow, that's really fascinating. Okay, so I need to circle back around to I had one more question about the diagnostic protocols that you use. So for women who've emailed me or have contacted me through Instagram, and I've tried to explain, I've sent them your papers and your research. I've told them to buy your book. I'm going to plug your book again. Everyone buy the book. They still, obviously, because it's a whole thing to jump on a plane from the United States and come over to London for, a scan and a surgery. It's a thing. And so I don't blame women for wanting to grasp for ways to be able to stay in the United States or stay in North America, especially during COVID, whenever they may not even have a choice. But a lot of them are like, well, can I just tell my sonographer to turn on the color flow? Can I just ask them to just turn on the color flow and see if it's that way? And I don't want to answer the question for you, but I'm guessing you would say, like, no, it's not as simple as just turning on the color flow. It's actually a tremendous amount of training and technique that has to be learned in order to diagnose this properly using these techniques.
And unfortunately, yes, you're quite right. It is. We are trying to work with one of the ultrasound companies at the moment to make it easier and to semi-automate it. And if that research works, then it might be easier. The difficulty we've got is a lot of vascular technologists are excellent at doing duplex ultrasound, but know nothing about gynecology. And a lot of radiologists and ultrasonographers who come from a gynae background know all about gynae and all the gynae organs, but have no idea about vascular technology. And why Judy Holdstock is so good, and Angie White and Charlie Harrison, is because they're doubly trained. All of them are sonographers who have got very big experience in gynecology and have done years and years of gynecology transvaginal ultrasounds, and are also vascular technologists. So they understand it's about the anatomy and the physiology. I mean, the thing with it in the short term, in the commercial sense, as you know, because England doesn't charge anywhere near what the States do for the operation, it's actually still cheaper for the flights, the hotel, and to have it done than it is to pay in the States. But we're hoping that the UK prices might start going up to make that not the case. And we're also hoping, obviously, that more American doctors will get on board with what we do and start offering this sort of thing to American patients. But at the moment, actually, although it is a hassle to get across, I don't think the cost is actually that dissimilar when you add the whole lot together.
Well, okay, so in my case, I don't have health insurance, and a lot of people in the U.S. don't have health insurance, and for us, it's a matter of income wise, we fall right in the category that we make too much money to qualify for any type of tax credit or discount on the premium cost. And we don't make enough to pay full price for it. So like I would have to increase my income $1,800 a month just to pay the monthly premium for insurance that's available under the Affordable Care Act. And that's not even including, then I would also be out, you know, about $14,000 for deductibles for my family. We don't spend that much on healthcare every year. So, I mean, if we, you know, if I had cancer or some other kind of debilitating illness or had a disabled child or something like that, I could totally, you know, see how that cost would be justified for us, but that's not our case. So we've just chosen to continue going without health insurance, and thankfully we can pay for everything that we need so far out of pocket, which we did with coming to your clinic. And I said this before in my video with Dr. Beckett, and I want to say it again on here so that people understand that when I went to the interventional radiologist in the States, in America, he was only going to embolize my left ovarian vein, and he was going to use a venogram to do the main diagnostics of it, because at that point all I had was a CT and only the left ovarian vein, and I didn't have insurance, and so I had to prepay with the hospital because it was an OR and in a hospital, a day surgery. There was a team of people, the venogram cost, the cost of the coils, his time, all of that. And the hospital wanted $63,000 for one vein. And I came over there and I had a better diagnostic. I had better diagnostics with the ultrasound that you and your team do. I had both of my internal iliac and the left ovarian vein done, which needed to be done. And including my travel expenses, Airbnb, transportation, all of that, we were out less than $14,000. Yeah. So, and I know $14,000 is a lot of money to a lot of people. It was a lot of money for us. I mean, we had a GoFundMe, and my grandfather chipped in a big chunk of money for us, and like it was a big deal for us to get there. But the reason why I tell people, you know, a lot of people say the same thing to me too. I can't afford it. I don't have that much money. You know, I need to find somewhere where my insurance will pay for it. Is that, first of all, good luck getting your insurance in the United States to pay for pelvic congestion. I cannot tell you how many emails I've gotten from people who their insurance doesn't think that this is a real thing, and it won't pay to have their treatment done. Or it will only pay for the left ovarian vein because that's the most common, you know, that's what's recognized. And, you know, then also just for a lot of women have told me that their doctors have told them that this is in their heads. Like, because they've had ultrasounds done, they've had a CT scan done, they don't have endometriosis, they don't have uterine fibroids, they don't have adenomyosis, they don't have cysts on their ovaries, but they have all of this pelvic pain and heaviness and bloating and no one can tell them that this is actually what it is because they're not doing the right kind of diagnostics to even look for it. And a lot of gynecologists don't even believe that it's a real condition. What would you say to any of that?
I totally agree with you. I mean, on the financial side, we just dream of being paid $63,000 to do a pelvic ambulance. I mean, we'd only work 1 day a week if we actually earned that much. So you know, it makes us feel very cut price. but you know, on the other hand, I think probably because of the NHS England undercharges, but on the other hand, I'm not sure that what America charges is also, you know, they obviously have their own system, but there must be a middle ground somewhere. At the moment, it just means that we can do the quality we do is world class, as you know, but we are constrained by how much we would be able to charge in the market. So it's good for you at the moment that we can keep low. What's interesting what you say about the all in your head. I mean, this is I've got some very good friends who are gynecologists, and you know, we're very happy chatting about most things, but we always fall out over pelvic congestion. And whenever I start talking about pelvic congestion, what's really interesting is I quite often say to them, you know, what about these women who have got pelvic pains that you can't diagnose? And they say, well, you do your laparoscopy, you do your MRI, and you know they've got no cysts, and they go through the list like you've just done, because that's what's on the gynecology websites. And I say, yeah, but what about the veins? And they go, oh yeah, they've all got big veins, but we're looking for other things. And they're actually physically seeing the problem, but because they're not taught that veins can cause problems, they just ignore it. But they're seeing it time and time again. Now, there was a time when people thought that venous leg ulcers, you had to have a deep vein thrombosis. They thought you had to have bad deep veins, and it was a terrible thing, and you could only wrap it. We published the book on the leg ulcer treatment revolution, showing that if you treat the varicose veins, most leg ulcers disappear. So most people with leg ulcers disappear because it's just the big veins causing stasis and reflux. You treat them, the leg ulcer disappears. Pelvic congestion is the same thing as a leg ulcer, but in your pelvis. The same inflammation that over the years causes a leg ulcer at the ankle is the same inflammation in the pelvis is causing you that pain as a pelvic congestion. When you do the same treatment, block the veins off and stop the stasis and reflux, it disappears. I mean, anyone these days who think pelvic congestion syndrome doesn't exist really is 20 years out of date. What we've got and what I explain in the book is there is a group of patients, probably about 20%, who nobody can find a good cause for, like no ovarian cysts, no cancers, no endometriosis, no thing. They have got reflux and veins, but when we treat them, they don't get better. So we know that 80% of people who have got proven pelvic reflux with our tests get better. But there's 20% who still have some other cause for their pain. And we know that's true because we also know that some people who have got classic symptoms of pelvic congestion, when we scan them, also have normal veins. So although we can treat the majority of patients, we'll get good results. If there's nothing else found, if they've got the veins that we can see, and if we treat them. But there's this small number, as our diagnosis tests are getting better, that 20% is getting smaller and smaller, but we still quote 20% at the moment. And what we need to have, there needs to be a better test just for saying this pain is caused by this vein. But the trouble is we haven't even got that in legs. So we've known about leg varicose veins for 5,000 years. so this is still quite new.
Yeah. Well, I'm, as a patient, that's extremely validating to hear you say that like this pain is real and that doctors aren't even looking for the veins, because I mean, man, when you can cut out a tumor, veins seem kind of boring,
But what's really interesting, I mean, the thing with it is, I mean, I spent a lot of my life saving lives, doing aneurysms, bypasses and everything. And before that, I was a general surgeon, and my training, and did the cancers and everything else. And, it's fantastic being the hero in the hospital. And when I went to veins, a lot of people turned around and said to me, you're just wasting your time, all that talent you've had in the past. And you're doing. But the reality is, when you actually look at the figures, and this is now being proven by the National Institute of Health and Clinical Excellence, if you do veins properly and you do them right, and we're not just this is leg varicose veins, because we still know that most people doing leg varicose veins are not specialists and they don't get good results. But if you follow all the latest research we're doing and you do the veins properly and you get the recurrence rate that we have down to the same as if you've never had veins, which is 3% per year, then the quality of life improvement you get for the whole of the rest of your life, when you actually put that into dollars, is that in fact better than any cancer treatment or any vascular treatment. And it's because you're treating young and middle-aged people who've got decades ahead of them and preventing clots, bleeds, skin damage, leg ulcers, time off work for pain. You're just preventing all of that for the long term. And in fact, proper venous disease treated properly is more cost effective than almost any other medical intervention. But it's just not sexy. And that's the problem. It's because you don't see that, that somebody rising from the dead and, sobbing people suddenly. It's not emotive, but actually doing it badly gives you a lifetime of hell. Doing it well, it was, I just had my veins done once, and you forget about it. And it's a huge thing to get the veins done properly. And that's why I spend my life studying veins.
Yeah, well, you're my hero.
Thank you.
You're my hero. I don't have the long years of having some mystery pelvic pain like a lot of your patients do, and a lot of people who've contacted me on the internet. They've been suffering for years. I didn't have that, thankfully. I did have several months of really intense, very difficult pain, lots of bed rest, lots of confusion, anxiety, depression, all of that. But I have forgotten, like, I don't remember anymore that I have these 13 coils in my pelvis. Like, I just don't remember anymore. And I remember when I came to London and you were sitting with David and I in your office going over all of this. And I was like, well, what can I expect for the future? And you were like, a lot of women just forget they even had this done. This whole mess is over with and it's behind them and they just forget about it. And if it wasn't for people emailing me twice a week and contacting me on Instagram, I would have forgotten about it a long time ago.